Good morning, everyone, and welcome to our Friday morning program, TIRO MDS. We really have a wonderful program this morning. I'm thrilled to introduce Dr. Fabian Pitoia, who has been a presenter on this platform in the past. He is the head of the thyroid section of the Division of Endocrinology and Investigation Area Coordinator at the University of Buenos Aires. He is currently the President-elect of the Latin American Thyroid Society, and he is actively involved in numerous both national and international societies, including the Endocrine Society, the Argentine Society, and the American Thyroid Association. We are also joined this morning by Dr. Rhoda Cobin, who's a long-term colleague and friend. She is clinical professor of medicine at the Icahn School of Medicine, where she was chief of the endocrine thyroid clinic for many years. Dr. Cobin, interesting, was founding board member as well as a former president of the American Association of Clinical Endocrinologists, as well as president of the American College of Endocrinologists. She has been a frequent contributor to many of our THANC Foundation annual courses. And with that, we're going to be discussing a topic that all of us have been challenged with over the past 2 years. And so this, I anticipate, will be an extremely fascinating presentation from Dr. Pitoia regarding the impact of the pandemic on decision-making and outcomes in thyroid cancer. So thank you, Fabian, for joining us here.
Thank you very much, Mark, for the invitation. I enjoy very much sharing this, although as we were talking in backstage, probably this is a topic we want to forget at this time. We do not want to speak any longer about COVID-19, but we learned perhaps some interesting things from this pandemic. And I am going to show you a paper we published by the beginning of the pandemic. It was around 100 days after the beginning of the pandemic, how we moved with the lockdowns at that time. And sorry. And then I am going to show you some data regarding these predictions we made at the beginning of the pandemic and how it moved during the following years. So when we talk about COVID-19 and cancer, these are the numbers of COVID infections, registered COVID infections up to March of this year, being the largest number in Europe and also in America, now in the US, I mean the continent, the number of infections that were registered. And there was an initial prediction on the impact of patients with cancer in general, that there would be a delay in diagnosis, a decrease in genomic interrogation due to change in priorities of laboratories. Probably this was not as much important as it is today in 2020, because we had at that time only 4 drugs, larotrectinib and trectinib, dabrafenib and trametinib, as drugs who were target genomic alterations. And now we have some other drugs like sapercatinib, persetinib. But probably this could decrease the number of diagnoses in this group of patients and the delay in controls. The director, the NCI director at that time predicted that there was going to be a reduction in the number of mammographies and colonoscopies. And he suggested that over the next decade, there would be around 10,000 excess deaths. We cannot know what is going to happen with this situation yet, but we have some new data regarding what happened with the screening tests, at least in the US. These are This is a study from 748 referral centers showing what happened with the screening test, the monthly screening test volumes, and they measured what happened before and after the pandemic was started. And they found, interestingly, that there was not a decrease in screening rates from breast cancer and lung cancer, but yes, a decrease in the median relative percent in monthly screening tests, around 18% in patients with colorectal cancer and around less than 7% for cervical cancer. So we do not have data about the number of increase of diagnosis of this type of tumor, but probably this is the first data regarding the decreases in screening. There was also, by the beginning of the pandemic, a decrease in the accrual to clinical trials of around 30%. And there were two studies which addressed the impact of cancer in patients with COVID-19. One was the CCC19 study, and the other one was the TIRO study. The first one had 928 patients evaluated with different types of tumors, and the second one only 400 patients with thoracic cancers. The first one was from 3 different countries, and the second one from 121 centers from 20 countries. And considering the first study, the CCC19, there were 30 patients with head and neck tumors. Here, they not discriminate what types of head and neck tumors did this patient have. But we can see here that older age was a factor that increased mortality almost 2 times, also the male gender. The performance status 2 compared with performance status 0 or 1 in patients with cancer with 4 more time risk of mortality when the patient had a COVID infection. The cancer presence versus remission almost 2 times, and the cancer presence when the patient was progressing with his or her cancer versus remission with 5 more times more risk of death. Here we can observe the forest plot for this situation. Additionally, there was some data about those patients who received cytotoxic systemic therapy, and a first data that appeared about the surgery within 4 weeks of COVID diagnosis. This was by the very beginning of the pandemic, showing that probably those patients who receive a surgery after the COVID infection can have or could have a higher risk for mortality. So these are the comparison of these 2 studies which were not directed to thyroid cancer patients, but there was probably an increase of mortality, an increase of hospitalization, being 50% for CCC19 and 83% for those patients with thoracic tumors. So going specifically to thyroid cancer, what we did during the beginning of the pandemic, one of the things we tried to look at is mainly put these patients into the time of tumor volume duplication time, the growth of these types of tumors. And we know that for those well-differentiated thyroid cancer, mainly papillary thyroid cancer, we could be relaxed. We do not need to hurry. We could take the thing smoothly without going to any urgencies. But of course, and these are pictures of patients we have seen by the beginning of the pandemic, when we have an anaplastic thyroid cancer, poorly differentiated thyroid cancer, or rapidly progressive medullary thyroid cancer, we should move fast and not take into account that we were during the lockdown at that time. We proposed that probably surgery, the immunosuppression by hypercortisolism after surgery, the anesthetic drugs and the analgesic with immunosuppressive effects would have an impact in the outcome of patients with COVID infection. So surgery was tried to avoid it in those patients with diagnosis at that time. And there was an analogy at that time proposed by Dr. Shaha that COVID-19 and thyroid surgery should be done like an analogy with pregnancy. What we usually do during pregnancy with thyroid cancer, the unavoidable surgery should be for those fast-growing tumors, independently of cytology, the poorly differentiated thyroid cancer, and of course, those patients with anaplastic thyroid cancer. This was a study addressing specifically the issue of mortality considering the timing of surgery following COVID infection. And this was an international prospective cohort study which tried to evaluate the 30-day mortality rates stratified by time from the diagnosis of COVID. And there were 140,000 patients from 116 countries, and 2.2% of these patients had preoperative COVID infection. So the authors divided the COVID diagnosis, the time from COVID diagnosis to surgery between different weeks, 0 to 2, 3 to 4, 5 to 6, and longer than 7 weeks in this group of patients. The majority of patients were asymptomatic at the time of surgery, not symptoms or resolved. And here you can observe these were the data for mortality of those patients who had no preoperative COVID infection, and how it increased almost 4 times for those patients who had an operation. I am talking about all types of operation, not talking about thyroid cancer specifically, but we can see here that the risk of mortality was higher between 0 to 7 weeks of 6 weeks of having COVID infection. So this paper that was published last year took a very nice conclusion that when we have a patient and this patient has no urgencies, we should wait until week 7 or 8 to postpone a surgery after COVID infection. So what we did by the beginning of the pandemic and the lockdown in our center and our hospital, we postponed all fine needle aspiration biopsies. Our hospital was almost entirely dedicated to COVID between March and August. And we made only 7 fine needle aspiration biopsies, 2 excisional biopsies, and 10 thyroid surgeries in 100 days, with a decrease of 98% of our previous situation regarding these procedures. And in low-risk papillary thyroid cancer diagnosis at that time, we proposed active surveillance, only 2 patients. I want to only to show this because active surveillance is not very well accepted in Argentina. Here we have our publication from 2020 showing that from 286 patients with the criteria for active surveillance, only 25% of these patients in Argentina accepted active surveillance before the pandemic. And this is what happened in Canada with the paper of Anna Soka, showing that prior to the pandemic, almost 74%, 75% of patients chose active surveillance over surgery. And during the pandemic, 96% of patients chose active surveillance. So going to the second point, what happens with remnant ablation? So we, as Dr. Shahad did with pregnancy and surgery for those patients with thyroid cancer and COVID, we try to do the same with radioiodine, but the analogy with our recommendation was the same we do for those patients who had a thyroid cancer, they were operated on, and they are looking for pregnancy. I mean, patients who are near their 40 years old. So we usually do not delay if there is a high risk of recurrence of suspicious of diagnosis of distant metastasis. We usually delay in intermediate risk of recurrence and not recommend, of course, remnant ablation in low risk of recurrence, and we base our decision regarding the dynamic risk evaluation. At that time, we did not indicate any radioiodine dose in 100 days in our patients. And when we look at the data about the impact of delay in radioiodine administration in metastatic thyroid cancer, we have some data showing that if you delay more than 6 months, there can be an impact in overall survival in patients with metastatic thyroid cancer, with a decrease of survival in this group of patients, and the increase in the risk of death of almost 4 times. There is also a very nice paper from our region, this is from Brazil, showing what happened. This is a normal situation they have in Brazil with the delay in the administration of radioiodine. We do not have that trouble here in Argentina, where we can administer radioiodine if we want during the first 2 or 3 months after surgery. But here they evaluated if there was an impact of this situation in patients, dividing all of them according to the risk of recurrence. So you can here have low risk, intermediate, and high risk of recurrence. And in a darker color, you can see that there was no difference for the excellent response to treatment when at a low risk of recurrence, intermediate risk of recurrence, or high risk of recurrence were compared. So these authors did not find any impact on the delay. I would say that probably the number of high risk is not high, and probably we cannot assume this as a real truth, but I think that probably for intermediate risk and low risk of recurrence, this may be the fact. So there was a study trying to determine the impact of COVID-19 in patients with thyroid cancer. And they tried to see the impact of radioiodine therapy, the previous administration of radioiodine therapy in patients with thyroid cancer, compared with those patients who did not receive radioiodine therapy. And they did not find any statistically significant difference between hospitalization, ICU admission, intubation, or death in this group of patients. So when we go to the follow-up of our patient with thyroid cancer, this is our paper talking about that those patients who have an excellent response to treatment usually will keep this response during the long-term follow-up independently from the risk of recurrence. So this probably could be a bit different in the literature for those patients with high risk of recurrence. There are some data showing that when you have an excellent response to treatment in those patients with high risk of recurrence, the risk of a structural incomplete response at long-term follow-up may exceed the 10% of a structural incomplete response. But these data were very useful for at the beginning of the pandemic, because we decided that those patients who had an excellent response to treatment didn't need to hurry up for a control. And the same happened because of the data we already had published by different authors, that those patients who received total thyroidectomy without remnant ablation or only lobectomy, probably low or low intermediate risk of recurrence, The risk of a structural incomplete response for those who had an excellent response to treatment was really very, very low, around less than 2%, and in one paper around 7%. So what we did during this first 100 days is that we postponed those consultations for those patients who had an excellent response to treatment, who already had a thyroid cancer, they had received total thyroidectomy, lobectomy with and total thyroidectomy with or without remnant ablation, and we postponed these consultations for the end of year 2020. And we moved to postpone most of those consultations for those patients with biochemical or indeterminate response, mainly because we knew that these patients had a previous control and there was a stable thyroglobulin, and we did not have any structural incomplete response showed up in the previous control. And we made telemedicine for these patients only in 3 cases. And for those patients who had a structural incomplete response, we had a presential consultation, and we decided to perform active surveillance of these lymph node metastases that were found in these 7 patients. Those patients under active surveillance, at that time, 52 patients were followed up by telemedicine. There were some data from the Memorial of New York trying to address this topic of the telemedicine and how endocrinologists and endocrine surgeons felt at the Memorial of New York with this situation. And the barriers identified were mainly the difficulty in expressing empathy, the decreased ability to coordinate care with the interdisciplinary team, and the lack of the physical examination. This last point seems not to be very important for thyroid cancer because we have ultrasonography and other methodology, but interestingly, in this paper, they talk about the impact, the psychological impact that this may have on our patients when we palpate the neck and we say we do not find anything in the palpation, and the relaxed the patient feel with this situation of being palpated by the doctor is something that cannot be done when we do telemedicine. And the benefits is the compliance with social distancing measures and the convenience for patients with low risk of recurrent thyroid cancer who presented for follow-up. And so the characteristics of the patients who acceded for telemedicine visits were those patients with differentiated thyroid cancer or medullary thyroid cancer with American Thyroid Association low risk or intermediate risk with excellent response to therapy, patients who live far from the hospital, including international patients or patients' preference, and in-person visit those patients who were symptomatic, new patients, the patients on clinical trial, patients with differentiated or medullary thyroid cancer who were intermediate risk or had incomplete response to therapy or progressive disease, or the high risk of recurrence, or the patients who had who lacked technological skills or adequate internet service, and of course the patient preference. So when moving at the end of this talk, talking about advanced thyroid cancer, probably from the data we have from other cancers, we could assume that there would be a higher risk for worse outcomes in COVID infection in patients with advanced thyroid cancer. We know that this group of patients may have hematological toxicity when they are receiving multikinase inhibitors, mainly neutropenia and lymphopenia. This is not very frequent, but we can observe this between 5 to 13% of these patients treated with sorafenib and lenvatinib, and maybe increased by the elevated cumulative doses of radioiodine that may have an impact on the bone marrow. So we did not postpone any control of our patient with advanced thyroid cancer during the beginning of the pandemic. And this was our real life for advanced thyroid cancer in the first 100 days of the pandemic. So we evaluated with telemedicine the evolution of the disease to determine if there was stable or progressive disease in 9 patients. And there were 22 patients from these 31 patients with advanced disease who went to our hospital. And these patients who had progressive disease, we initiated a multi-kinase inhibitor in 15 of them, and there was a delay in our healthcare insurance approval by around 2 months from when we indicated the multi-kinase inhibitors. We had 4 patients with first-line treatment, 10 patients with second-line or indication of external beam radiotherapy, and 1 patient that was included in the COSMIC 311 clinical trial at the time of the pandemic. We increased telemedicine, the contacts to control adverse events in patients with advanced thyroid cancer by 147%. And this was a patient who had a diagnosis of anaplastic thyroid cancer by the beginning of the pandemic. This was a 52-year-old patient with a past history of a papillary thyroid cancer with a structural incomplete response with no control during 4 years, and he had a cervical mass progressing in 3 months. By the beginning of the pandemic, he went to our hospital, and this was one of the excisional biopsy we performed at the beginning of the pandemic. And that time we initiated lenvatinib 10 milligrams per day when we had the diagnosis of anaplastic thyroid cancer as a bridging therapy while we were expecting the results of the BRAF analysis. And when we had finally the results of the BRAF after these 20 days, the patient was started with dabrafenib and trametinib. And these are things that happens usually in our country where we do not have probably we wouldn't have the approval of these 2 drugs so fast as we could do with this patient. But this was a donation from a patient who was cured from a melanoma and found on the internet that it could be used for patients with thyroid cancer. And he contacted me through the media and donated this treatment for this patient. So here you can observe what happened by the beginning of the pandemic. Here 7 days and 14 days after starting dabrafenib and trametinib with a dramatic decrease of the tumoral lesion. Here some of the images. They were not very nice images at that time because this patient couldn't do it in a referral center. So we have these images showing the disappearance of this large anaplastic thyroid cancer. One of the things that we recommended for this also was in our paper, is that, of course, the initiation of multi-kinase inhibitor shouldn't be stopped in any patient with advanced thyroid cancer. We should be based on the performance status, the tumoral burden, the disease progression, if the patient had a disease potentially symptomatic or symptomatic. And so we try to recommend to avoid any delay in obtaining images. For those patients who were under multi-kinase inhibitors, we said that these patients should keep the social distance and lockdown, to respect them, to register all the adverse events and communicate the adverse events to the medical team through telemedicine, and do not postpone images and control. And the special situation, what happened with this patient under dabrafenib and trametinib, We faced some troubles because this patient presented with fever. Fever is one of the most frequent adverse event with the combination of the dabrafenib and trametinib. It may happen in around 30 to 40% of cases. And this was the case with our patient. So this patient had like 4 or 5 swabs while he was treated with the dabrafenib and trametinib. We needed to discard that this patient was not infected, had not COVID infection. So finally, we assumed this was a situation mainly because this patient was going to many centers at that time, and we didn't know much about the infection, about the way of transmitting infection, and so we did these swabs several times for confirming that this patient did not have a COVID infection. So to end my talk, I would like to say that when we talk about COVID-19 and thyroid cancer, we know, we probably assume that it may have a worse impact on patients with advanced disease. We had no COVID-related death in this group of patients, although there were 7 patients with COVID infections, but they did not have a worse outcome. And there was probably, or there won't be any impact on those patients with low or intermediate risk of recurrence, mainly in those patients who have an excellent response to treatment. And I think this is something we have learned from this last decade to learn to be relaxed with this group of patients. And probably there was a nice conclusion in the Lancet Oncology with this very nice image of a patient going through the pandemic. And probably we should take this pandemic as an opportunity to reduce and eliminate low-value practices, I would say now in endocrinology, not only in oncology, because we know we are doing probably much more screening in patients with thyroid cancer that need it. And mainly, I say, for those patients who have an excellent response to treatment. Thank you very much.
Thank you very much. That was really a fascinating talk, and all of us would certainly like to be able to put thoughts of the pandemic behind us, but you've done a wonderful job of really summarizing some very valuable insights. Let me ask you this, and you started to allude to this at the very end of your talk, but do you think there are any lasting lessons learned about the management of thyroid nodules, thyroid cancer, that will endure in a post-pandemic practice of thyroidology?
Well, I think that you mean the diagnosis of thyroid nodules, what to do with this patient, not when we are talking about thyroid cancer, before you say.
No, so I think probably thyroid, I would imagine the diagnosis of thyroid nodules will not be impacted here. But any lessons learned that you think from managing thyroid cancer patients that will endure beyond the pandemic?
Well, I said that for most of our patients, we followed this idea that came initially from the memorial of being more relaxed with the follow-up of these patients. And we already had this idea, so the pandemic probably didn't impact very much our approach. But I think that this lesson can be taken by the general endocrinologist who is always worried about the thyroid cancer, and he wants to perform remnant ablation in every single patient, and he wants to do everything and the follow-up in every single patient. And the pandemic touch, I think, gave these doctors an input, and very important input, of saying, well, it was 1 year or 1 year and a half, I didn't do any control to a thyroid cancer patient. He came 2 years later and he is doing really very well, and everything is perfect. So probably this is something that the physicians will incorporate during their career if they know how to learn probably what happened and read what happened in the pandemic. And I don't know. It's very difficult here to see that, because now we are seeing a rebound of consultation of those patients who didn't come after 2 years. And I would like really to see what is the impact on the physicians about the future. Would these doctors that usually control a thyroid cancer patient who has an excellent response to treatment, even every 6 months, with a control of laboratory thyroglobulin, ultrasonography, because it is done here. We see it all the time. And this would have an impact. Probably a survey with this in the general community would give us an idea of this learning process during the pandemic.
Great. Do you, one follow-up question do you have any sense on whether or not the extent of thyroid surgery was impacted by the pandemic? Meaning, was there a trend towards performing lobectomy because of concern about keeping patients out of the hospital, risk of the impact of hypocalcemia, or the risk of patients getting access to thyroid hormone? Was there a trend that you could detect?
Well, you know that I didn't read any paper related to these. Probably, I don't know whether you have read something, but we have another trouble here, that it's very difficult to convince our surgeons to move to lobectomy. We are just starting this year to pressure a bit more to start with lobectomies, and we are trying to find a result. There was a long time here where we tried to fight with the surgeon, saying that total thyroidectomy need to be done in every single patient with thyroid cancer. And now to go back to the lobectomy has taken more time than we wanted. And I would say that probably we will have this change by the next year. So when we indicate lobectomies in patients, there are many times that these patients come back with a total thyroidectomy. And we saw it with this paper I showed before of 290 patients who had a tumor smaller than 1.5 centimeters. And 98% of these patients, although we indicated lobectomy, were treated with total thyroidectomy. They were there, they went to their surgeons, and then after hearing the surgeons, they decide to move with lobectomy. And this happens because many of these patients were not seen in our team, in our medical team at the hospital. They have different social securities that need to be operated outside of our hospital.
Dr. Cobin, do you, I don't want to monopolize my questions here. Do you have any a particular question you'd like to raise?
Mark, thank you. And thank you, Fabian. I think that was a wonderful talk. I have one question and then a few comments. So my first question is just very simply, your paper, which was published last year, and your talk focused on what you knew up to 2021. We're now in 2022, and you talked about the rebound, patients coming into your clinic afterwards. And I think one of the issues that's on people's minds, which I think I can answer, but is with your longer follow-up, the people that you didn't see in clinic or that you didn't even see in telemedicine, in other words, people that just didn't present to the medical system, in your longer term follow-up, are you seeing more cases with more advanced disease. And I'll just quote one paper that came from Wuhan early in the study, and obviously they had, the earliest experience with COVID, and they surveyed, I think they had 6 hospitals in Wuhan that pooled their data. They had a slight increase in the people that showed up after COVID, in people that presented with either multicentric disease or local regional metastases or extranodal extension, or there was slightly more advanced disease. However, their numbers were very small in that regard, and they didn't have any increase in mortality in people who didn't have distant disease, which is what you'd expect. At Sinai, in New York, we haven't got exactly quantitative data, but just an unofficial poll of the people who are seeing patients in our clinic as well as our private practitioners. That seems to be the case also, that we don't see more advanced disease in people that just didn't show up at all. And probably that will mean for the future that there really isn't much change in their prognosis compared to people who would have perhaps been less reluctant to come into clinic earlier. So I'm just wondering, in 2022, with the follow-up now of people coming into your clinic, are you seeing more advanced disease? Are you seeing more difficult cases because these people just stayed home?
No, in fact, these are not quantitative data. It's only an impression. So I cannot say exactly, but I have the impression that we do not see any more advanced disease, mainly because we focused on these patients by the beginning, our patients, and we gave the opportunity to everybody who was referred to our hospital to be seen very fast. Sometimes, perhaps I would say that probably what we are seeing is those patients who had an intermediate or high risk of recurrence, having a local recurrence that was not controlled in the last 2 years. But we know that probably for most of these patients, this structural incomplete response in the lymph node would not have an impact in mortality. And probably it can be treated, it could be treated 2 years ago, and it can be treated now with the same situation. I mean, for most of our patients, of course, that we have patients who have a rapidly progressive disease, but if you have a lymph node, a recurrence in a lymph node that was 1 centimeter last year, and then 1 year later it is 1.5 centimeter, it probably won't change anything if that patient goes to the lymph node dissection 1 year later. And we have learned this from most of our patients with differentiated thyroid cancer. Of course, that those patients who have a rapidly progressive growing thyroid cancer will go to consultation, because this is something that is really relevant, and we are not seeing any difference for these patients with advanced disease.
Thank you. I have the advantage of historical perspective, because I've been practicing endocrinology probably for longer than most of you. And I think that it almost illustrates the idea of the pendulum swinging, because when I first started, when I was a fellow, there actually were no sonograms. And there were, the people who came to medical attention were people who either palpated something, or their doctor palpated something, or perhaps they knew they were at high risk, but even then, familial well-differentiated cancer wasn't even recognized as an entity. And I think the SEER data over the course of decades kind of proves that point, that we have, although we've seen a lot more diagnoses of thyroid cancer, we really haven't seen any significant increase in death, and certainly not death from well-differentiated cancer that's confined to the thyroid, or even, as you said, to some of the local lymph nodes. So this sort of forced or non-discretionary experiment in no treatment or no diagnosis, because people weren't coming into our clinic. At Sinai, our clinic was closed for almost 2 months. And then when it opened with much more limited access. The waiting rooms were closed, no chaperones were allowed, so many people who couldn't navigate on their own didn't come in. Our fellows did not all come to clinic at the same time. The rooms were reduced because of, you know, they had to be cleaned and so on. And so many fewer people were actually coming into the clinic. And there was also this big factor in New York, especially, and I would imagine in Buenos Aires and elsewhere, where patients themselves were avoiding seeing doctors and avoiding coming into the hospitals because they were fearful that they would catch COVID by coming in. So this was almost, for a few months at least, like what happened in 1970 or 80, where we only saw patients if they presented with clinical disease, not because of an incidental finding on imaging or because somebody was worried or what have you. So it almost was like turning the clock back. And I think that Mike Tuttle would probably agree with me that maybe that's a good thing. You know, maybe we all know that there are small cancers that are found at autopsy. I remember writing a monograph in the 1980s where we cited some of the old autopsy data where where they showed a very significant incidence of undetected thyroid cancer in people who died at very advanced stages of other diseases. And so that thyroid cancer actually had no impact whatsoever on their clinical course or their life. And I think you could say that not seeing people during COVID was taking us back to that era. And now with seeing that really didn't make much difference, I think that strongly supports Mike Tuttle and Memorial Group's original idea that we're doing way too much screening. We're picking up on things that probably have no clinical significance. And so as your last slide pointed out, this experience during COVID is perhaps a way of emphasizing to people that this massive increase in thyroid cancer diagnoses over the last couple of decades has really burdened the system and created a situation where we're spending money and putting people through procedures that they maybe don't need without much benefit in terms of reducing morbidity or mortality. So it's sort of a future back to the back instead of back to the future. And maybe that's a good thing. So I think one of the take-home points from the COVID experience is that we shouldn't ignore things that show up. If somebody is doing a PET scan for another reason or a sonogram of the neck for another reason and they see a thyroid cancer, then it's obvious this whole system of risk stratification is really important. But even the not seeing people at all, not making the diagnosis at all, may not be such a terrible thing. And I don't know what you think about that and what Mark thinks about that. I know that Mark can speak to this better than I, but I know that our surgical volumes for quite some time, many months, decreased because of the imperative to save rooms for COVID patients and the lack of ORs and so on. But I don't think in the long run that may make any difference at all.
Fabian, do you want to comment on that?
Yeah, I agree, completely agree. This was my original idea with this thought and saying, but I find it will be difficult to be changed in the future. We probably will need a guideline saying that we need to stop doing this. But I find it difficult because even patients with a diagnosis of a thyroid nodule here in Argentina, with a stable thyroid nodule, you will have an ultrasound every 6 months. So it's very difficult to say a patient why a patient with a thyroid nodule should be controlled every twice a year, and a patient with a thyroid cancer can be controlled once every 2 years when he has, or every 1 year, or he doesn't need to go back to endocrinologist. That can be seen by the general physician with the internal medicine doctor, with no need to go to the endocrinologist if he or she continues with an excellent response to treatment. This probably can be done in the US, but here it's completely different because patients access to endocrinologists directly. They don't need any referral. They go directly for the consultation. So I find this really a subject of education, not only to patients, but also to the health insurances, and it's money. Of course, it's a lot of money. It's money that endocrinologists will lose from not seeing these kind of patients. So there will be, I think it will be very complex to take it back to what it is really needed.
Well,
Go ahead. Go ahead.
Well, what I was going to say is that, practicing in New York City and in the suburbs of New York City, I couldn't agree with you more that particularly patients who know that they have a thyroid cancer, even the small cancers, in New York, at least for a while, it was extremely difficult to convince patients that active surveillance was a reasonable option. Our patients sort of were known for being rather demanding patients and somewhat anxious patients. I have a cancer, you need to take it out. I have had cancer, I see another small lymph node. Mark and I can tell you about many cases that, excuse me, that we followed over the years, and I'm sure that Mike Tuttle can as well, that speak to the fact that those patients who allowed us to not intervene are actually doing quite well. And I think that spreads within the community, and that may make a difference in other locations where community word of mouth almost combined with education of patients and education of physicians, what may make a difference in how they approach things. I will say one thing, and this kind of speaks to the fact that during COVID, we couldn't examine patients. The telemedicine is not a good substitute for physical exam, besides the issues that the Memorial Group raised about empathy and so on. When you can't examine a patient, it certainly does leave something, although again, most of these small cancers and certainly most of these small lymph node mets, you can't feel them anyway. But I think psychologically, it's reassuring to patients when you put your hands on them and say, oh no, I don't feel anything there, or no, you look fine, or yes, you look quite healthy. On the flip side, there have been a couple of papers very recently, not directly speaking to COVID, but indirectly, and that is the whole issue of, should all small cancers undergo active surveillance rather than immediate surgery, not just from an economic point of view, but that there are some small cancers where their behavior may not be as benign as some other small cancers. And so doing molecular testing on biopsies, if you're going to do a biopsy, may make a difference. It may or may not change our perspective on who should be biopsied, because right now the pendulum is swinging toward don't even biopsy these smaller lesions. So, are we missing some that may behave differently? And there again, COVID gave us a good lesson in, if we don't even see them, but nothing happens, maybe that's okay.
Fabian, let me just ask you another one other question here. We're very familiar in the US the fact that there is a preponderance of patients with thyroid cancer who are managed in community settings. Can you comment whether that is indeed the case in your healthcare system? And has this, as the result of the pandemic, been to push towards more regional care rather than patients coming into major medical center for thyroid cancer?
Thank you. It doesn't happen here, Mark. The thyroid cancer patients are only seen by endocrinologists. They are not seen by never you will find an internal medicine doctor to see a patient with a thyroid cancer. The access to endocrinologists here is easy, and a patient with thyroid cancer will only be seen by an endocrinologist. That's why we have like an overcharge of those number of patients with excellent response to treatment who goes every year to their control, and even for the control of the dose of levothyroxine that could be done by the general practitioner, well, we do it. And it is normal. It's our way of moving here in Argentina. So probably this also should be changed, because this is an overcharge of work for consultations, but this is money too. So it's very difficult when you talk this about the hospital population, but these are another group of patients that pay for this, or the social insurances pay for this, and the endocrinology is paid for that. So how we will change this, it's not easy.
Great. One other question. In your paper, you talk about the impact of thyroid hormone on the immune system. And I believe that most of that was swayed towards hypothyroidism, but in TSH suppression, does that impact the immune system to an extent that making those patients more vulnerable to viral infection?
I don't really know that. Cannot answer that question. Probably we were talking about the hypothyroidism situation, but I don't know exactly that answer. We had published a second paper with the people of Pier Paolo Trimboli in Europe, and we tried to make like a whole picture of the impact of COVID in the thyroid gland, not only talking about thyroid cancer. And there we talk about the different diseases that can be triggered by COVID. And most of the patients we see are with subacute thyroiditis. That is something that we see very, very frequently. Even now, after the vaccine, we are now reviewing data about after vaccine, the number of published cases with subacute thyroiditis. But I cannot talk about the impact of hyperthyroidism in immunity about what you asked me.
Fabian, there's a question regarding differences in the rate of use of Thyrogen during the first few months of the pandemic. Was that in any way influenced relative to a non-pandemic period of time?
There are some papers published, I think a Jordan paper, talking about the increased number of the use of Thyrogen during the pandemic. But as I said before, we did not indicate radioiodine in these first 100 days of patients. We do not have an increase in the use of Thyrogen. I would say that, again, our group is moving to the dynamic risk assessment all the time, mainly for low risk and intermediate risk of recurrence. And when we indicate radioiodine for those high risk of recurrence, we try to use hypothyroidism in most cases, because it is not approved for metastatic disease. So we try to move, although there are data that Thyrogen can be equally effective in patients with metastatic disease, we try to use the general recommendation of administering radioiodine after hypothyroidism, only 2 or 3 weeks of hypothyroidism. So I don't have data regarding our use of Thyrogen, because it's really very, very low at this point of our careers. Great.
We are approaching the 9 o'clock hour. I can't thank you enough for just a wonderful lecture and really insightful comments from Dr. Cobin. Thank you both, everybody. Unfortunately, 2 years into this, as we probably one of the final things that I mentioned back 2 years ago is for everyone to stay safe, and those words continue to resonate here. So thank you once again. Please join us again next week, and everyone be well. Thanks for joining us.
Thank you, Mark. It's a pleasure.